Hello, thank you for joining us today. My name is April Gamble. I work in Can't hear me? Now can you hear me? Okay. Hello, thanks for joining us today. I'm very excited to be here. My name is April Gamble. I work in Kurdistan, Iraq. I work with an international NGO called Center for Victims of Torture. And I work on building capacity of local physiotherapists to treat survivors of torture and trauma. This includes refugees from Syria, displaced persons in Iraq, and survivors of ISIS. And it's very exciting to be here today with these 4 other physios. We all specialize in working with survivors of torture and war trauma, and we hope to share our experiences with you today. As the circles on the map indicate, the 5 of us work across the world and with populations from many different regions of the world. We hope that by sharing our vast experiences, you can gain a new perspective in learning how to work with survivors of torture and trauma. So before we get to the details of the presentation, I'd like to give you an opportunity to better understand the experiences of this unique population through this video. As the video depicted, survivors of torture and war trauma are increasing globally. And as physiotherapists, you will encounter this population regardless of the country you live in or the setting that you work in. Therefore, we'd like you to be prepared to work with this population. Today's symposium is focusing on the application of modern pain science in the treatment of physical and psychological effects of torture and trauma. The 4 speakers will describe various physiotherapy interventions and service models that are trauma-informed and evidence-based and seek to enhance functional independence. Throughout these presentations, we will reflect on the cultural, social, psychological, and environmental factors that influence physiotherapy care. Persons who are refugees, asylum seekers, or internally displaced have all experienced psychological trauma from war, conflict, and/or forced displacement. Additionally, torture is very common among this population, but the exact statistics are difficult to attain. Research has demonstrated that many of these individuals present with mental health problems like post-traumatic stress disorder, or PTSD, and major depressive disorder. But as you can see here, even a greater percentage present with persistent pain and associated functional impairments. The high rates of pain can be attributed to biopsychosocial factors, prolonged high-stress situations, and limited access to health care at the acute stage of an injury. Therefore, we as physiotherapists have the unique skill set to help these individuals recover and return to function. In recent years, modern pain science has really changed the way that we as physiotherapists approach the treatment and assessment of pain. It's outside the scope of this presentation today to talk about the details of modern pain science. Rather, we hope to demonstrate how you can apply it to this population. As you can see here, we now understand that there are many, many factors or inputs that contribute to persistent pain. Pain is incredibly complex, and it's our role as physiotherapists to understand this complexity. And so I just want to highlight a few things specific to this population. Culture and social background and norms influence one's pain experience and expression. Different cultures and people groups present with different physical symptoms following psychological trauma. For example, in some African countries, chronic headaches are very common, while in the Middle East region, chest pain and shortness of breath are common expressions. Additionally, we know that thoughts and beliefs about pain are an integral factor in persistent pain. One's culture and previous experiences contribute to one's thoughts and beliefs, and therefore understanding the social and cultural background of your client is essential to addressing pain and function. Today, you're going to hear these presenters reflect on how the client's culture influenced their treatment approach and their outcomes. As I shared earlier, this population often has comorbid psychological symptoms and mental health disorders like PTSD. As you can imagine, this influences emotions and the regulation of emotions. It also influences protective memories, or those memories that our brain uses to evaluate the degree of threat that a situation presents with. So due to this complex presentation, a trauma-informed physiotherapy approach is recommended. This entails integrating an understanding of the impact of psychological trauma on the biological, social, and psychological realms. So through our presentations today, you're going to see how we do that in clinical practice. And with chronic pain, and central sensitization occurs. And central sensitization is a series of complex physiological changes in the peripheral and central nervous system that increases the sensitivity of the full system. It's hypothesized that survivors of torture and trauma are subject to high rates of pain due to experiencing prolonged states of severe stress. And this influences the central sensitization process. It's also related to the environment and the context of these clients and this population, which can range from camps for refugees or displaced persons, continued risks to threat and risks to safety, new countries where they possess limited language skills, financial instability, and limited work and education opportunities. We as physiotherapists have the responsibility and the skills to influence all these inputs to persistent pain. You will see in the next hour the interventions that physiotherapists can offer to this unique population. You will also see how we as physiotherapists are working on goals and functioning in the biological, psychological, and social domains. So I'd like to introduce now our very first speaker. She's my good friend and colleague from the Center for Victims of Torture in Kenya. So please welcome Jepkomoy Joanne Kibet. She works in Kenya with refugees from many different African countries, including Somalia, Ethiopia, Uganda, Rwanda, and Burundi.
Good afternoon, and welcome to our session. I'm going to share with you my experience working with survivors of torture in Kenya through a study that I did. So the aim of the study was to determine the effects of physical activity intervention on pain and health-related quality of life of survivors of torture. We employed the pre-test, post-test design, and we had 60 survivors of torture that were recruited into this study. In this study, they had to undergo 10 sessions in a period of 10 weeks, and they modeled use exercises and pain education as an intervention. And each session lasted between 1 hour and 20 minutes and 1 hour and a half minutes. 1 hour and 30 minutes. The outcome measures that we used in this study were pain catastrophizing scale, the fear avoidance beliefs questionnaire, the disability rating index, the WHO quality of life PREV, and visual analog scale. All these outcome measures measured the different aspects in those particular clients. Just to give you a brief demographics about these particular people, they came from several countries. Majority of them came from DRC Congo, Somalia, Uganda, Burundi, Eritrea, Ethiopia, and Rwanda. Survivors of torture in Nairobi really experienced many types of torture in their countries of origin, ranging from beatings, death threats, rape, sodomy, witnessing family members being killed, persecution because of sexual orientation, Al-Shabaab attacks, and many others. Coming to Nairobi or fleeing to Kenya to get to a place of safety, they face a lot of challenges on the way coming, and on reaching to Nairobi, they also still face really dozens of challenges as well. There's no social support. There's no housing for them in the urban setup. There's no schools for the children. They don't have access to health care and food. Security is not guaranteed either, and they are vulnerable to exploitation, arrest, and detention because of their legal status, and especially if their refugee status has not been determined by the UNHCR and the government. Therefore, the experience that they go through, we can call it a continuous trauma kind of experience. So one of the methods that we use to attend to these people is through pain neuroscience education. And pain neuroscience education is described as a continuous process in which it's initiated during an educational session with patients prior to commencing their active rehabilitation program. Understanding pain physiology changes the way people think. The evidence is that people in pain are interested in learning more about pain, not necessarily the anatomy, the biomechanics, or the pathology of the problems that is causing them trouble. The pain neuroscience consists of education sessions for patients describing in detail the neurobiology and the neurophysiology of pain and pain processing by the nervous system. Explaining pain to clients aims at reconceptualizing the pain as a protective input of the brain rather than an accurate measure of tissue damage. So why did we choose to do this? We chose to do this so that we can alter the pain perceptions of these particular people, so that we can increase function and physical movement, so that we can reduce disability and increase function, and so that this can also act as a short-term pain relief and they're able to do the activities of daily living with ease. In this study that was done in Cambodia, it was one of the studies that was done on survivors of torture, and 40 people were recruited, but 34 of them completed the study. And the model of pain education was employed in this study, and they went through a couple of sessions. And the conclusion of the study was that the pain school content was culturally adapted and it was transferable. The quantitative outcomes also showed significant improvement. That means that it was significant, the treatment was significant, and clients and therapists also gave qualitative feedback about the sessions that they had. There is some good evidence that shows that there's some good research evidence that shows that people who are physically active have less problems with their chronic pain. Chronic pain limits a lot of survivors of torture in doing their functions. Exercise and physical activity not only have benefits in healthy individuals, but also have proven to have good benefits with patients. Therefore, therapeutic exercises help patients to have improved pain control. When it comes to hyperarousal, therapeutic exercises reduces the symptoms of hyperarousal, body tension, sleep problems, among others. And this is because their bodies are always in the state of high alert and as a result of previous traumatic experiences. Research has shown that regular exercises and physical activity lowers the prevalences of chronic non-communicable diseases, such as heart attack, hypertension, diabetes, among others. Research has also proven that adults who engage in regular exercises and physical activity experience fewer depressive and anxiety symptoms, therefore supporting the notion that exercise offers a protective effect against development of mental disorders. Participating in regular exercises and physical activity leads to decreased PTSD symptoms, anxiety, and depression. Now I'm going to put you through, explain to you through the model of Judith Amman model, which is a trauma-informed approach model that we use at the Center for Victims of Torture. It's a model that has 3 stages: the stages of safety and stabilization, the process of reconstruction, and the last stage of reconnection. In each and every stage, it has specific functions that employed or given to clients. In the first stage of safety and stabilization, activities in this stage include identification of functional goals, light interactive exercises such as with balls to encourage partnership and social interactions with other group members. Then pain education is also a key component in this section in order to address the negative false pain beliefs and that may be causing kinesophobia or avoidance of movement and further compounding the existing problems. The next stage of process of reconstruction, clients are taught to identify and acknowledge their existing capabilities and limitations. They are encouraged to acknowledge that what is real limitation to movement and what is perceived limitation based on the fear of avoidance. Okay. And on the last part of reconnection, clients focus, the main focus on this stage is to teach the clients or the group members on how to use what they've learned in the session to help them maintain the improvement they've made in everyday functional activities. And the activities that emphasize on good posture, correct lifting, are also practiced in these sessions. In this study, we first started by doing the translation and cross-cultural adaptation of 2 tools. That was the pain catastrophizing scale and the fear avoidance fear avoidance belief questionnaire. Then thereafter, we did a baseline measurement that we used the 5 tools, and then the clients went through 10 intervention sessions over a period of 10 weeks. That meant that they came to the session once per week, and then they were also assessed 2 weeks after the intervention, and that period we're calling it a 3 months assessment, and then at 6 months, we did it 3 months post the 3 months assessment. If you look at that, the clients, most of the clients complained about low back pain and shoulder pain. And this, most of the time, these are the areas that they complained that they were tortured. And then followed by lower extremity complaints, and then the chest, the abdomen, and the torso. And very minimum of them complained of problems with the upper extremities. In our, after the intervention, you can see there the impact of physical activity on fear avoidance questionnaire. Before the intervention, the score was high. And then after the intervention, at 3 months, the scores dropped. And they continued to drop further at 6 months. So this was really good. And then the impact of physical activity intervention on quality of life. You can see there at baseline, that is at intake before the intervention, it was at 51.8. Then after the intervention, it went up to 58.7. And then between 3 months and 6 months, it dropped further than even at intake. And there are really so many reasons that affect that. One of them could be because of movement from one area to another area, the security checks that are present in Nairobi, and especially this year being the election year, and such things also affect foreigners, and especially the people that don't have proper legal status. With pain catastrophizing beliefs, clients at intake, they reported higher, and at 3 months it dropped, and between 3 months and 6 months it slightly peaked, but this was statistically significant. Then the effects of pain on daily function. We looked at the using the visual analog scale and the DRI disability rating intakes. And you can see that with the disability rating intakes, there was very minimal change in terms of improvement in function. They improved from baseline to 3 months. That was the period during the intervention. And then after the intervention, that is between 3 months and 6 months, it further dropped again. That means maybe the people were not doing the work that, they went back to not doing the work that they had gained. And then for pain, it was good because it dropped from intake to 3 months during the time of intervention. And it even dropped further from 3 months to 6 months. That was great. So my take-home message to you people is that exercise and pain education is effective within a multidisciplinary treatment approach, and that trauma-informed approach is a feasible program that we can apply in physiotherapy. The experience of pain in survivors of torture and trauma is associated with a wide range of psychological consequences. And I would encourage you to do lots of research on this area because there is very limited research that has been done by physiotherapists in this area. Thank you.
Thank you, Joanne. I'd now like to welcome Justine D. She works with the University of Vermont, and she works with refugees from Somalia, Sudan, Bhutan, Iraq, and Burundi.
Thanks, April. I work with an organization called the New England Survivors of Torture and Trauma, and this organization is an interdisciplinary organization consisting of clinical psychologists, social workers, physical therapists, attorneys, and physicians, meant to try to capture and address all of the needs of this population. The study I'm going to talk about today is a pilot study. It's a precursor to some work that I'm going to continue doing. I was trying to standardize a model of care for this trauma-informed care. I have been using this trauma-informed model on the refugees that I have been treating, and it has been very promising, but of course it needs to be evidence-based. So this was a feasibility study to determine if it was acceptable to the participants and if it was feasible to implement in practice. So the study aims were, as I had just said, examine the feasibility of this model of care to treat chronic pain and disability in survivors of trauma, and assess the acceptability of this model of care to treat the chronic pain and disability in these survivors. This was a case series, and it consisted of 2 patients. The patients had had pain for greater than 10 years. They both had a history of depression and anxiety, and the second one also had post-traumatic stress disorder. And so these 2 patients participated in the total 6 visits. The 6 visits consisted of pain education, graded motor imagery, and an exercise program. The outcome measures that I used were the brief pain inventory, the PROMIS 29, the patient reported outcomes measurement information system, which is a measurement tool that captures 7 different domains, and I'll talk a little bit more about that in a bit. And I also used a regional specific functional tool. So subject 1 had chronic low back pain, so I used the Oswestry Disability Index for her. And the second patient had a lower extremity problem, and so I used the lower extremity functional tool for that patient. So the first component of every visit was 15 minutes of pain education. So it was similar to Jep's study. And we tried, over the course of the 6 visits, we tried to address all of those topics within, by the end of the 6 sessions, all of these topics were covered. So we looked at what was the patient's kind of misconceptions about their pain. And that was probably the biggest thing that we had to address, that movement was not bad, movement was not going to make their body worse, and that it wasn't going to harm them. So once they understood and grasped that concept, it really made the treatment easier. So that's usually where we started. We then followed up with some neurophysiology of pain, some of the central changes that are occurring with central sensitization, talking about excitability. So instead of talking about pain, we talked about more how sensitive they were that day, because certain triggers can make the person more sensitive and experience greater pain. We talked about how the brain changes when you have chronic pain, and it isn't that they were crazy, they really do have pain, and it's really, there are studies that demonstrate that our brains do change structurally when we have chronic pain. We worked with ways of trying to calm down and desensitize people, meditation, breathing exercises, and we talked about sleep hygiene because many of these clients have difficulty sleeping. So after the 15 minutes of pain education in our hour session, we then moved on to graded motor imagery. And this is a form of therapy that's designed to address the central changes that occur with chronic pain. There's evidence that shows that when in patients with low back pain, there's evidence that shows we lose the ability to discriminate between left and right sides of our body. And so if you don't address this change, it's difficult to address the chronic pain. And we use this Recognize app, which is from the NOI group, and it's an app that can be downloaded to an iPad or a phone, or if you do not have accessibility to electronics, they have cards that can be used, or you can even use magazines or newspapers where you have the patient circle all of the left extremities or all the right feet, or when the person is side bent to their left or right side. So there's ways to adapt it if there are not electronics available. The second stage of the graded motor imagery is doing imagined movements. And so you try to activate the brain pathway without activating the motor pathway. So if a patient is fearful that lifting a box is going to hurt their pain, you have them try to imagine the movement. Or sometimes even imagining lifting the box will trigger the person's pain response. And that's one of the ISAP definitions of pain, is actually potential tissue damage. And so then you have them imagine someone else. So I'll say, imagine me lifting the box, or imagine April lifting the box. And they're like, oh, that's easy, I can do that. And you have them practice to reactivate the neural pathways in the brain to try to get it from the pain pathway or pain neuromatrix that they've developed over time. And then the last phase is mirror therapy, and you can see the image up here where if the involved extremity is the left hand, it's hidden behind the mirror, and so the patient is seeing the right hand move. And this has been studied widely in patients with complex regional pain syndrome or reflex sympathetic dystrophy or phantom limb pain. And this is also changing the pain pathway. So the patient looks in the mirror and it appears that the involved painful limb is moving freely and easily, and it's not activating that pain pathway. So just some evidence for graded motor imagery. As Jeff was saying earlier, there's not a lot of evidence for these treatments, and there are some studies that have been done, but they definitely need more subjects, and more studies do need to be done. The first one is by Plaisir, and it's sensory motor retuning in complex regional pain syndrome parallels pain reduction. And what these authors did, they looked at patients who had upper extremity complex regional pain syndrome, or RSD, and found that they took fMRIs, functional magnetic resonance imaging, and they found that these patients pre-intervention had decreased cortical mapping of the primary and secondary somatosensory cortexes, and they also had impaired two-point discrimination sensation, and both of these findings correlated with their degree of severe pain. This study only had 6 subjects, and these 6 subjects underwent between 1 to 6 months of graded sensory motor retuning, which was basically a desensitization program and an exercise program. After the treatment, the post-fMRI demonstrated restoration of cortical mapping size, so it was similar to normal patients who did not have complex regional pain syndrome. The patients had decreased pain, and they had improved two-point discrimination. Another study by Mosley was graded motor imagery for pathologic pain, and this was a randomized controlled trial, but again, there were only 5 studies that met the criteria for entry into this. Oh, I'm sorry, this isn't the right one. This is our RTC. I'm getting ahead of myself. So in this RTC, they were looking at subjects with complex regional pain syndrome or phantom limb pain. And these subjects were randomly allocated to either a graded motor imagery group or a traditional physiotherapy model of care. And so in the graded motor imagery group, they had 2 weeks of the left-right lateralization training, 2 weeks of the motor imagery, and 2 weeks of the mirror therapy. So there were 6 weeks of treatment. In the standard care, they had some exercise, and they had education, and not pain neuroscience education, but lifting, body mechanics type of education, and a home exercise program. And so after the intervention, there was a statistically significant difference in pain reduction and improvements in function in the group that had the graded motor imagery. And these gains were maintained at a 6-month follow-up. And so the last study that I'm going to talk about for evidence for the graded motor imagery is this systematic review that only had the 5 articles. And in this systematic review with the 5 articles, it did show that there were positive findings using graded motor imagery to treat patients with chronic low back pain. So I was trying to translate that evidence from complex regional pain syndrome, patients with phantom limb pain from amputations, and patients with chronic low back pain to the survivors of torture and trauma, because I figured if it works in one population who has chronic back pain, it's plausible that it would work in another population. And then the last bit of my exercise program was exercise, and this consisted of a 30-minute exercise program. So at every visit, there was some cardiovascular exercise, and I say this with a caveat. So when we first started, the cardiovascular exercise consisted of 2 minutes of walking. The patients were like self-selecting how much they were going to do because they were fearful it was going to make them worse. And so over the course of the 6 visits, they improved to up to 15 minutes of either walking or sitting on a little stepper machine. We did lower extremity functional exercise, which consisted of exercises that could be done at home. So it was body weight type things like sit to stand or mini squats or supine bridges. We did some upper extremity exercises. Again, all exercises that the patient could do at home. And the exercises were progressed at each session. So after the 6 visits, we had the 2 participants complete a post-intervention survey, and these were the questions that were asked of the participants. So we wanted to know, did the pain education help? Was the GMI, graded motor imagery, useful in reducing their pain and improving their function? And the subjects found the trauma-informed physical therapy approach to be moderately to extremely useful in reducing their pain and improving their function. They both stated they knew more about their body, and they were very satisfied with the frequency of the physical therapy visits. So we felt that the feasibility of the model of the 6 visits was also met, that aim was met. We were able to complete all of the components that we set out to with the pain education and graded motor imagery and establishing a good exercise program for these patients in 6 visits. And the outcome measures that we chose were all able to be done within 15 minutes. And so we felt that the data collection to demonstrate change in this population was feasible for a therapist to do in an outpatient clinic setting. Some of the secondary findings that I hope to explore more with a larger study and sample size, we found that these subjects demonstrate an improvement in pain and in the functional outcome measurements. So in looking at the brief pain inventory, so this on your left is subject number 1. So the pain severity on the BPI went from a 6 to a 4.5, and the pain interference went from a 6.6 to a 5. On the second subject, the pain severity decreased 5.3 to 4.5, but this person had a really good decrease in the pain interference. She went from 8.1 to a 3. On the PROMIS 29, the domains that this tool assesses, it asks questions pertaining to physical function, satisfaction or quality of life, anxiety, depression, fatigue, sleep disturbance, and pain interference. And in both subjects, physical function scores increased, anxiety decreased, depression scores decreased, fatigue decreased, and pain interference decreased. We had some mixed results with satisfaction, where satisfaction increased in subject 1 but remained the same in subject 2. And then sleep disturbance increased in subject 1 but improved in subject 2. For subject 1, who had chronic low back pain, in addition to her emotional issues and psychological issues, her Oswestry Disability Index score went from a 50% disability to 42%. So she had a decrease of 8 points. And the subject number 2, her lower extremity functional scale, which is a 0 to 80 point scale, with 80 points being fully functional and 0 not functional at all. She started at a 19, which is very low level of functioning, and she improved to a 37. So a 9-point change is a clinically meaningful or minimal detectable change with this tool. So she really improved in her function. So what did we learn from my pilot study? I learned that trauma-informed physical therapy is feasible and acceptable model of care, and that this model can be implemented in an outpatient physiotherapy practice setting. The data collection tools are feasible for clinical use, I believe, and also for future research use. And further research is definitely needed to now look at the effectiveness of the different models. So the pain education model, graded motor imagery, and the exercise, and with a much larger sample size. So that's it.
Thank you, Justine. I'll have everyone stand up and stretch, wake up your body before we bring up the next presenter. So we have 2 more speakers, and then I'll do a conclusion, and we'll have questions. So our next speaker is Anmet Kar, and she is from Denmark. She works with refugees from Lebanon, Afghanistan, Iran, Kurdistan, and Syria. Feel free to stay standing and move if you want.
You can keep standing if you want. Yeah. Hello, thank you for coming, and thank you, April. Just shortly about myself, I've been a physiotherapist for 22 years, and I have my primary experience from working within the psychiatric field. For the past 8 years, I have worked at Dignity, Danish Institute Against Torture, that is seated in Copenhagen, Denmark. I'm here to share some of the headlines, the results from an intervention study that I did for my thesis at the master's program at the University of Lund in Sweden. The headline for the study is Basic Body Awareness Therapy, also called Bbad, and Pain Education in Traumatized Refugees, and I used a single subject experimental design, and it's to be seen as an explorative study. In this study, I'm combining Bbad treatment with educational input on pain in individual treatment. So at Dignity, we treat people with a refugee background that have asylum in Denmark and that suffers from PTSD, very often with severe biopsychosocial challenges. We approach these challenges with a holistic interdisciplinary approach from physiotherapists, social advisors, psychologists, and medical doctors. I wanted to explore the effect from a well-known physiotherapy method without the help from the other professions. So a bit about the method. Bbad is a Scandinavian developed physiotherapy. It is a movement awareness modality consisting of a structured rehabilitation program first developed in the 1970s, inspired by Nordic holistic physiotherapy approaches and Eastern philosophies about the balanced and harmonious human being. In Bbad, the body ego is seen as an integrated part of the total identity, and the main elements are the body's relation to the ground, the balance line and balance, centering of movements, coordination, breathing, and flow. Being aware of the movements in the here and now and being in relation to others are also central aspects. The respiration's ability to adjust to the rhythm needed for a movement is leniently practiced in Bbad. This means that a tolerance for internal sensations are practiced, which is what the traumatized refugee patient suffering from anxiety and chronic pain could use to help beat their need to use a fear avoidance strategy during movement. The therapy also contains simple massage techniques which practices the tolerance for external sensation. The physiotherapist does the exercises with the patient so the patient mirror what to do. No direct correction on movements are done. So far, a number of trials have been carried out using Bbad as the main method treatment for patients with illnesses as schizophrenia, depression, anxiety, and pain. These show moderate evidence on lowering levels of pain, anxiety, and depression. Lower levels of bodily tension, better balance, centering, flow, and free respiration is also seen. The use of Bbad within the treatment of traumatized refugees in Scandinavia is well known and considered best practice, but it's poorly documented through trials within the patient group of traumatized refugees. So, in this study, for the educational inputs on pain and PTSD, I used the physiotherapy pain school manual that was developed at Dignity some years ago. The topics addressed acute pain and chronic pain, PTSD and pain, sleep and pain, and activity and pain. It contains both knowledge and self-care tools. The knowledge was given when it felt clinically relevant throughout the Bbad treatment. So, my objectives for the study was I wanted to explore how a physiotherapy method, Bbad, and educational inputs on pain and PTSD influenced pain severity, anxiety, movement quality, body function, and experience. The questions I wanted to explore was it feasible for the 7 participants to carry out the treatment and the monitoring connected to the design? Did reported pain and anxiety symptoms change over time, and did they correlate? Did the intervention improve body function, movement quality, and experience? And what were the pre-post group trends for anxiety, depression, pain severity, and pain interference? So the participants came from the Dignity waiting list. They were waiting for an interdisciplinary program. 4 males participated, 3 females. 1 person was from Iraq, 1 from Lebanon, 4 from Iraq, and 1 from Syria. They were all unemployed at intervention start. The 4 males had a long history of working experience, and the 3 females had no working experience prior to the study. The inclusion criteria were they were to have PTSD and have reported pain and anxiety symptoms on a daily basis for the past 3 months. They were to have no need for immediate treatment or help from doctor, psychologist, and social advisor. They were to have no abuse, no psychosis, and they were to be compliant for physiotherapy with moderate movement treatment twice a week, and also the extra monitoring connected to the study. So the monitoring tools that I used to set up baseline, I used pain severity and anxiety values, which was also monitored throughout the study. As for the pre-post assessments, I used the brief pain inventory short version that we heard about before, and I used the Hopkins Depression and Anxiety Scale, HSCL 25. I also used the Body Awareness Scale, Movement Quality and Experience, also called BAST MQE, and it's a validated and reliable assessment tool developed to evaluate body function, movement quality, and experience. And it's connected to the Bbad treatment that I'm using in the study. So here you see the study setup. We had 7 traumatized refugees. They self-monitored on a daily basis for 14 days to set baseline on pain severity. They measured the maximum level every day, the minimum, the medium, and the here and now levels, which gave me a daily mean value on pain severity. They also measured 5 anxiety items that I took from the Hopkins Anxiety and Depression Scale. And in the study, I only analyzed 2 of the items, nervousness and shakiness inside, and suddenly scared for no reason. Both the pre and the post assessments were blinded, and we looked at movement quality, body function and experience, anxiety, depression, pain severity, pain interference, quite a lot of things. And I used the evaluation tools that I mentioned before. The intervention setup was, each intervention lasted 50 minutes. An interpreter was used in 6 out of 7 patients. 1 spoke English. Each intervention was individually planned, and the time was more or less divided with 90% Bbad and 10% of educational inputs. Handout illustrations of the Bbad exercises were given out at intervention start, and the patients were encouraged to do the exercises at home between interventions, but I didn't do any registration of this. So each patient participated in individually planned 16 treatments in an 8-week period. And clinical status was done every time they came for the intervention at intervention start, using the same variables on anxiety and pain severity that I used in the baseline. After the post-intervention assessment, the data collection continued on a daily basis for 14 days at home, where they used the same variables as I did for the baseline. So, the data analysis, I did time series analysis on all 7 cases. On pain severity mean values, daily values, and nervousness and shakiness inside. I actually also did the suddenly scared for no reason, but I'm not going to mention that here. I'm only sharing some of the things with you. I also did a correlation of values between PTSD, pain severity and anxiety, and I used the Spearman's Rho analysis. For the pre-post test, on BPI, SSCL25, and BAS-MQE, I used the DNSCO, and I worked in the system of SPSS. So, I want to share a few of the time series analysis with you. I don't have time to go through all 7 cases. I will show you 2 very different visual illustrations of the pain severity mean value measures. So here we have one of them. So here we have pain severity mean values on this. Let me see if I can work this. Yeah, over here. Measure from 0 to 10. And we have the 3 periods here: baseline, intervention phase, and post-intervention phase. Whack. So then, if you look in the middle first, in the intervention phase, we see a visual indication of an autocorrelation between treatment and value decrease. The treatment looks effectful on pain severity. What challenges this visual effect using this method is if you look at the baseline phase prior to intervention, we see a drop in measure value right before intervention start. In this case, the patient actually showed a large effect on movement quality, body function, experience, and anxiety and depression too. Having this unstable baseline was expected. Many of our clients live very unstable lives, and we also know from prior studies and from experience that suffering from PTSD, pain, and anxiety often creates these unstable measures. So I was kind of expecting this. Another example, totally different example, is this from one of my female participants. And what you see here is she was actually the only of the 7 patients that had a slightly higher pain severity, slightly higher mean values on pain severity and post-intervention. But you see, she has kind of stable measures throughout the whole thing. Even though the pain severity scores was like this, she still showed a clinical effect on movement quality and body function, and also a slight effect on anxiety and depression in the pre-post results. So all in all, 6 out of my results on the time series, 6 out of 7 patients had indications of lower symptoms of pain severity and chosen anxiety symptoms during the intervention phase. And what I didn't put on the slide is that what we did see is that there was a slight increase of symptom load in the post-intervention phase in the 6 out of the 7 patients, but the measures were not as high as in the baseline phase. But we couldn't show a statistical effect, but visually it looked like that. And no indication of autocorrelation between treatment and value decrease was seen. I couldn't prove that. No clear correlation was found between chosen and anxiety and pain severity scores. And that actually surprised me, because that was my clinical experience that often connects. But my pre-post results, I found a statistically significant effect on movement quality and body function on a level of 0.007, on anxiety 0.001, and on depression 0.027. And of course, you should recognize a very, very small sample size. I was looking for trends, and all the results should be seen as indicators of outcome. So the 7 patients that I spent quite some time with shared many reflections and emotions throughout the study. And I must tell you about all those reflections another time. Without the patients, there would have been no project. So to end my presentation, I would like for the patients to invite them into the room just for a little bit with a few statements from 4 of them. Also to show the diversity of the experiences that they got out of the intervention. One said, "I went from taking 8 ibuprofen daily for my elbow pain to none, without you ever touching my elbow. It must be magic or something." I don't really feel any different. I have felt that it has been a nice and calm break from my life, and when I'm here, I feel less tense and have less pain. In the beginning, I felt a lot of pressure from having to do the exercises. I don't anymore, and I can do the exercises for a long time now. Once I'm home, I feel tension and pain come back. And the last quote was actually from the first time series that I showed you, the one that seemed to have really good effect of the treatment. And one of the things he said is that it has made me believe in the future again. I find myself playing with my children. I go out, walk long walks, and visit my family. So, what did we learn? It was quite feasible, the Bbad and the short educational inputs on pain and PTSD, used in a single subject experimental design. I had no dropouts and they came to all their appointments. Creating a steady baseline is a big challenge within this group. I expected that, and the small study also supported it. Some of the future questions, there are a lot, but some of the 3 things that I thought about to share with you is how and what do we monitor within this patient group? Are there patterns of non-responders and responders, both within this patient group and with the treatment that I chose to use in this study? And what could be a long-term Bbad training contribute to the quality of life and function for refugees who have been traumatized? Thank you.
Thank you, Anna-Mette. Now I'd like to welcome Laila Jakobsen. She is also from Denmark, and she works with refugees from Lebanon, Afghanistan, Iran, Kurdistan, and Syria.
Yeah, thank you, April, and thank you all for showing up and staying late this afternoon. I'd like to share with you how I, as a physiotherapist, work together with our family therapist on rehabilitation of refugee families who have been traumatized, and briefly look into upcoming data on whether this way of working influences the individual's level of experienced pain. Can the physiotherapeutic profession support the interdisciplinary biopsychosocial family treatment if and how physiotherapy can reduce the level of experienced pain by addressing relations in the family, thus not directly intervening with pain-reducing methods? So at Dignity, a team of these 5 healthcare professionals treats around 24 families a year with an average treatment duration of 10 months. According to the interdisciplinary treatment plan, the families receive a relevant combination of individual treatment, couples therapy, and family therapy. And family therapy is conducted by both family therapists and physiotherapists together, seeing both parents, youngsters, and small children. By addressing dysfunctional relations in the family system, we indirectly aim to reduce both individual trauma reactions like pain, sleep disturbance, aggressive behavior, anxiety, depression, improving how the family members conduct themselves in relation to each other and in society in general. So this is a list of the most common themes we work with in our families. As a physiotherapist, I address the very same themes as the rest of my team, but from a bodily point of view. Working with a combination of exercises, massage, training, and physio education. I mainly work with families in 2 settings. I might see 1 or 2 of the family members for individual treatment, addressing the symptoms that he or she presents, affecting not only him or herself, but also rest of the family. And I will, as mentioned, along with the family therapist, conduct family sessions. The team's main focus is always the family function, and so for me as well. Here you see examples on how I, as a physiotherapist, work on some of these themes from a bodily point of view. I'll just find the curse here, yeah. So you see here 3 examples on bodily expressions and the following tools I could choose to work with. Over here, sleep disturbance. This one is feeling secure, and the last one is regulating capacity. Every theme presents itself in a mix of both mentally and bodily reactions. As a family therapist, you are an expert on mentally presented reactions, but also very much aware of how these reactions is situated in the body. And I, on the other hand, is an expert on bodily reactions, having knowledge of the emotions and thoughts that they might be accompanied by. So based on body presentations, I work with normalizing muscle tension, with breathing, regulating capacity, sleeping patterns, vitality levels, ability to relax, and so on. I provide individual treatment focusing on these presentations to increase the individual level of function to support the client's ability to work within the family and to improve the overall family function. Or I work with the presented bodily symptoms and patterns directly in the family session with and between all family members. Working, for example, with sleep disturbances, I most often start with hands-on, using manual techniques to re-establish the patient's ability to within themselves generate the calm sensation necessary for falling asleep, solve practical issues, improve strategies, introduce a mindful relaxation technique, and over time, increase level of activity to make way for natural sleepiness. And the second one here, feeling secure in a new country requires feeling secure in the family, which again requires feeling safety in myself. Not experiencing security within your body can be hard to describe. Could be described as an ongoing smoke detector making a howling noise, though there is no longer any smoke. So again, hands-on in order to reduce alarm activation and support the system that is supposed to calm you down. Then slowly starting classic stability training, focusing on isometric hold and always clearly within the comfort zone. Succeeding rather than challenging, but slowly progressing by letting the patient manage more and more. As for regulation capacity and so on. So using a small sequence of a family session, I will try to take you through the physiotherapist's way of working in the interdisciplinary family treatment. So this is quite a long story, so just lean back. Mom's doctor wrote in his referral to our clinic that Fatima is a 45-year-old woman with PTSD. She has flashbacks, wants to isolate herself, shows signs of depression, and has problems with sleep. She complains of headaches and feels pain numerous places in her body. Fatima says she's too tired to take care of her home and her children, and despite referrals to several hospitals, she's not getting any better. In my opinion, she's getting worse, he wrote. In the session I'm about to present, besides me, the family therapist Tina, the interpreter, and mom, who's Fatima, and her youngest daughter, Sarah, at 11, is present. Sarah is at the moment in 5th grade. She is described as very sweet, but lonely and with no friends. She does poorly at school, is clingy with classmates, and needy in her contact with teachers. When we first met her, her body expressed a desire not to take much place. There was little eye contact and low stability in function. She had a rigid posture and was at the same time very restless, feet constantly moving from one poster to another with an unstable relation to the surface. During assessment, it was observed that Sarah acted overprotective. She showed signs of being overly involved to the point that for periods of time she could not go to school and was not able to distinguish her own feelings and emotion from her mom's. Her behavior and her bodily function appeared immature and understimulated. She was constantly aware of her mother's actions and reactions and had difficulties relaxing. Sarah acted almost like a spinning wheel, turning around, observing where her mother was and how she was doing. She assumed that Fatima was in constant pain and too tired to do anything. At a point, she even begged the health professionals to stop treating, saying that her mom could not take anymore and that she herself could not bear to see her mom so tired and in so much pain. In this session, we aim to work with the following themes: sensory regulation and self-regulation, sensations, relations, and empathy, stability and inner structure, and communication between mom and daughter. What we knew was that when we asked Sarah to her bodily sensations, she would reply like, "I feel it everywhere," or "I feel nothing." So we initiate a gentle exercise focusing on involvement, creating interoceptive awareness and the ability to direct attention to your own body as well as to the body in front of you. Two and two together, we will exchange a massage using acupuncture balls. Doing the massage, Tina and I work together, and Sarah and Fatima work together. So Fatima is standing behind the chair where her daughter is sitting, working the ball on the daughter's back. At some point, she briefly stopped the movement, and Sarah immediately turns around and says, "Do you want to stop now?" Mom doesn't answer, nor meet her eye contact. "Mom, do you want to change so I massage you?" Mom do not answer, and Sarah starts moving around on the chair. So Tina, the family therapist, starts this conversation. "Did you ask your mom if she wanted to change places?" "Yes," Sarah says. "So is it her turn now?" "Yes." So Fatima says, "She knows that mom is always tired." And Tina says, "So Sarah, you're thinking about how tired your mom is?" "Yeah, she should have some massage," Sarah replies. So Sarah jumps up, giggling and skipping around, pushes her mom down in the chair and starts to give her massage. For the therapists, this is a great opportunity to talk about verbalizing assumptions instead of guessing and start working on creating greater awareness. So we ask about sensations in the body, making way for Fatima and Sarah to become more aware of how to connect to and integrate their own feelings, behaviors, and thoughts. And I say, may I ask you both, where in your body did you sense that you needed to change positions? Sarah, I could see your body was moving around, and Fatima, I could see you standing all still. How did you sense that your mom wanted massage? Where in your body? Sarah points the ball on the back of her shoulder exactly where Fatima previously seemed to hesitate for just a second. "Right here, right around here," Sarah says. And I ask her, "What did you sense when you thought you were done?" No answer. "How did you sense it?" It was just, she got tired, Sarah says. And Tina then says, so you thought your mom got tired? Sarah said, yes. How were you sure? Did you ask your mom if she was tired? Yes, I did. She was tired, Sarah says, believing that she had actually asked her mom if she was tired. Of course, this focus continues in the subsequent sessions as they both slowly improve on bodily awareness and relational skills. And this way of working together for the two professions in a therapeutic setting opens up for a wider range of observations and a variation of paths to follow, creating growth for the families. But what happens on classic physiotherapeutic issues like strength, stability, flexibility, and pain? I will present you one slide from a small set of data of adults who have finished family treatment by physiotherapists and family therapists, plus to some degree individual treatment, and where none of the participants received specific pain treatment in-house, though they all initially reported different levels of pain. Retrospect, I choose the 20 adults from families that had ended treatment in the period January 12 to December 16, who initially presented one or more somatic disorder involving pain issues, who had received both individual trauma treatment at the physiotherapist and at the family therapist, plus family treatment involving both professions together, but no specific pain treatment. So treatment duration was between 6 and 41 months, average treatment duration 18.8 months. They were all monitored before and after treatment with brief pain inventory, BPI, measuring level of experienced pain, with Harvard Trauma Questionnaire HTQ-4, measuring PTSD symptoms, and with Hopkins Symptoms List HSCL-25, measuring anxiety and depression symptoms. And since the data is not statistically analyzed, I will show you just this slide on how the score is divided numerically. So here you see how scores are divided, how many improved, that's the gray area, how many worsened, the yellow area, and the, well, sort of brown or dark gray area representing wrongly or not completed tests, plus unchanged scores from pre to post. So the first column there, HTQ-4, measuring the PTSD, and the next one, anxiety and depression symptoms, and BPI here divided on 3 columns. The first one, the pain drawing, and the BPI-1, the pain severity, BPI-2, the pain interference. So first impression indicates an overall good improvement, and of course it is interesting that though only PTSD symptoms and anxiety depression symptoms have been directly addressed in the treatment, scores on pain symptoms seem to show a similar level of improvement. So, since this is very raw data yet to be analyzed, today we'll skip to the summary there. Besides the impression of an overall improvement, 5 out of 20 had a terrific outcome, improving on all 5 parameters. And by the way, these 5 adults with the best altogether outcome had only one thing in common, and that was long treatment duration. And the 5 adults with the poorest altogether outcome had only short time treatment in common. Meaning maybe we are doing pretty well in this very complex field, and maybe treatment duration is an important factor. So things to consider here, the very last slide. Well, you could consider lots of things, but I've chosen those 5 bullet points here. Where exactly are what exactly are physiotherapeutic tools in trauma treatment? There are a variety of ways to reduce pain. How is pain severity, anxiety, PTSD disorders, and level of function connected? How can physiotherapists play a part in family therapy working from a biopsychosocial perspective? And how can we expand our understanding of the profession in an interdisciplinary trauma treatment session? Thanks.
Thank you, Lila. All right, we're just going to take about 3 minutes now to kind of think about what are the next steps, and then we'll open it up for questions. So what can you do as a physiotherapist to better serve this population, and what can we do as a professional body to better serve them? So first, as a single physiotherapist, you don't need to specialize in this field as we do in order to take steps forwards towards enhancing functional independence. One important step is seeing your client from the biopsychosocial model. I hope you saw how the work of these physiotherapists took into account the culture, the social context, psychology, and previous experiences of their clients. And it's really essential to develop and carry out an effective treatment plan. You have to understand these different variables. And now we can come back to those factors and inputs that contribute to persistent pain. As a physiotherapist, you have both the responsibility and the skills to understand and address all of these factors. As you have learned, this population often presents with persistent pain, but also with comorbid psychological symptoms. So therefore, you can begin by screening for the psychological symptoms with all your clients and establishing referral sources and collaborations with local mental health professionals. But also recognize that we as physiotherapists have the clinical skills to treat these comorbid psychological symptoms. And I hope you also saw how developing the knowledge and associated skills of modern pain science and central sensitization are essential for treating survivors of torture and war trauma. The last slides of the presentation provide a lot of references so you can continue to learn more about this topic or further your journey on this. And also, the presenters described several key approaches: modern pain science, trauma-informed approach, and the family systems approach that Lila just described. These presenters also described novel interventions that have been shown to be effective and feasible for survivors of torture and trauma. You as a physiotherapist are in a unique position to facilitate functional recovery through the pillars that are core to our profession: movement, client education, and therapeutic alliance. And now we want to ask, what can our professional body do to move to enhance the access to and the quality of services for this population? Like with the advancement of all fields, we need research, education, and advocacy. But we also just need physiotherapists out in the field applying these approaches and interventions. And it's really exciting to be here today because the 5 of us really comprise the very few around the world that specialize in providing physiotherapy services for survivors of torture and trauma that work on physical functioning, but also mental health and functioning. And the way forward is to get physiotherapists like all of you excited to develop these skills and apply them in the setting that you work in. And we can't do this work alone. If we apply the biopsychosocial model, we should seek the contribution of psychologists, mental health professionals, community workers, social workers, and maybe most importantly, the population we are striving to support, the survivors of torture and trauma. We've seen that they have incredible resilience and that these individuals can teach us how we can support them during their journey of recovery. So thank you so much for listening, and we'll take any questions you have. Feel free to go up to the mics to ask your questions.
I don't want to kill everyone. Is it working? Okay. Sorry, Milana from US/Kuwait. And Justine, I was just curious in your application of graded motor imagery, if as you standardize the process and try to increase your population for research, are you starting at a certain point, like the vanilla testing, and basing what you do from there in terms of using the Recognize app? I don't know if you're starting at a certain point for each patient and then working into the context and all that type of thing. Yeah.
So I think you're asking if what I'm doing with each patient, where I'm starting? It was hard to hear.
Yeah, oh, sorry.
For the GMI, the graded motor
Yeah,
imagery.
for the
Yep.
graded motor imagery, how you're deciding where to start with each patient.
So what I've been doing is just following the kind of the Australian Neuro-Orthopedic Institute graded motor imagery model, where they start with the left-right lateralization. And so we have an iPad in our clinic, and I'll pull that out. And there's 3 different levels, and they have, if there's an upper extremity problem, they have hands. If it's lower extremity, they have feet, they have a spine, a cervical spine. And so I explain to the person through the interpreter what's, I want them to, identify, is it a left or is it a right limb? And it takes a little bit at first, and sometimes the client will have me push the buttons at first because they're not confident using the app. But then I've had other clients who actually will download the app to their cell phone, which I was really surprised. I was pleasantly surprised about that. But I always start with the left-right, and I'll have them do the first level until they're 85% accurate at a speed of 1.5 seconds or less. And that's the standard that's been put out in the literature. And usually I let them do it about 3 to 4 times, see 15 different images. They start to fatigue though. So the first is like a learning experience. The second test is, they do better. The third might be the best, and often if I have them keep going to do it again and again 4 or 5 times, they start to decline. And I've seen this consistently with multiple clients. So I usually have them only do it 3 times, and it doesn't take that long. It takes maybe 5 minutes. And then I can progress them through based on those criteria of 85% accuracy. I'll have them do home exercises if they don't have the ability to download an app using, just like as I described, a magazine or circling a newspaper. And if they don't have a magazine, we have a whole bunch in our clinic, and I'll give them one of the magazines and I'll show them that. And then once they get good at the left-right, the mirror therapy is the very last bit, but then I'll start doing more of the motor imagery. Although I did have one client who was from Bhutan, and she was nonverbal, and so I could not use the left-right at all with her. We just did more motor imagery. Her husband, she couldn't walk. She could walk, but her husband had to almost carry her into the clinic, and so we had to make the husband sit in the waiting room because she would say that she couldn't do anything with the husband. So we used more of the motor imagery with her. So imagine that you can walk. And she actually wound up being able to walk with a quad cane after a couple of visits. So it's really kind of individualized, but I try to start with the left-right and progress through.
If there's not another question, I have a second one.
Yeah, go ahead.
How did you choose to have 30 minutes of aerobic activity as your baseline? Is it just not loud enough?
I'm sorry, could you,
Yeah, for Justine again.
for Jep?
No, for you.
For you, Justine.
Yeah.
Oh, me.
Yeah, how did you choose 30 minutes of
Oh.
activity? Because I know a lot of patients with chronic pain, that can be quite ambitious.
I think I was just trying to package everything into that time period, and I felt
Okay.
like that was a reasonable place to start, and that was a reasonable expectation to ask someone to try to work towards in their home life, like after the 6 visits. I wanted to do a little warm-up. I wanted to just target the major large muscle groups of the body. So sometimes I would do 5 minutes of walking at the beginning and maybe 10 minutes at the end, and do some exercise in the middle. So I just kind of randomly chose that.
Thank you.
Go ahead at microphone 4.
No, yeah. Hi, I'm Maria Sandborg from Sweden. This is a question for Jebkemoy, Joanne. In your experience, and also in your study, did all the patients have the same amount of fear of movement and catastrophizing, or was there a big variation?
The fear avoidance and pain catastrophization scores for each person was different,
Yeah.
but it was a range. Yeah.
Because research has shown that if you have not a high degree of fear avoidance and catastrophizing, it is actually not a good idea to target fear avoidance or catastrophizing, because you can then evoke fear. of movement. So what are your thoughts on that?
When we use the pain education in 3 of our sessions, it actually helps to reverse that kind of perception.
Okay.
Yeah.
Thank you.
Yeah.
My name's Tori Madden from Cape Town. Also, Justine, just a question for you. I was also interested in your decision to use the graded motor imagery program. And I imagine that that might be from picking up some alterations in body perception in your patients. And so I was just wondering, did you assess alterations in body perception? And I guess that kind of leads on to a broader question for the whole panel. Are you seeing general patterns of altered body perception in victims of trauma and torture? Thanks.
That's a great question. I did not assess body perception. It was in my individual study of 2 subjects. They did fill out a pain diagram, but I didn't do any other type of body assessment or body awareness type of assessment. Did you do any? Oh, you did body diagram.
I didn't understand the question.
Did we
can't
do?
hear it.
I know
Yeah.
it's hard to hear you guys. Did we assess body awareness?
Yeah. The tool that I used in my study and that we use as a regular assessment tool at Dignity is the Bbad MQE that is developed to assess body awareness, movement quality and experience. So it's coming out in English, I think, within the end of the year.
And in general, we all do see a lot of impairments in body perception and body awareness. One of the gaps in research and in clinical tools, though, is kind of having a tool to measure that. But we see it, and we make clinical observations, and we see it improve, and that we integrate treatments for it, and that's essential for getting the functional outcomes.
Afternoon. My name is Zoe. I've got a question on the patients that you've dealt with. I know that some patients that you spoke about have probably been tortured or something. And I know that obviously one of the modalities is, well, interferential, whatever it is. If at all you've treated these patients, have you ever had experiences where you don't get compliance or you don't get cooperation? Because the sensation that you get when you are having interferential therapy is almost similar, I would suspect, to being tortured. How do you cope with that kind of patients? Thank you.
Sure. That's a great question. So part of a trauma-informed physiotherapy approach is recognizing that some of the interventions and our interaction with the client can trigger those kind of symptoms or can trigger re-experiencing symptoms of their torture. So I have to understand what each client presents with, and sometimes it might be something like electrical stimulation can trigger that, but it could simply be moving their back can trigger those experiences because they were tortured on their back, or input to their feet. So each client presents differently. And so part of it is establishing that therapeutic alliance, that feeling of safety that allows you to set up the environment where the client can benefit from those interventions. But it takes a lot more pacing and support to get to that point where you could use some of those interventions. Anyone else want to add?
Sometimes we have special considerations when we are attending to this type of population. We have to consider the space between the therapist and the client. Sometimes we have to consider gender, like for example, if a client was raped definitely as a woman, then that client cannot stand to be seen by a man. So we have to consider the client to be seen by a lady. Sometimes they can't stand mirrors because probably they were tortured in front of mirrors. Sometimes we don't put on uniforms when we treating these clients because most of them have been tortured by government militias or government police or government army and all that, and they put on uniforms. So they associate the uniforms with torture. So we actually put special consideration to the environment where we're treating the client. Are the windows open? Do the client prefer the door to be left open? Do they prefer to have exposed area that we are treating and all that? So we put a lot of consideration in treatment.
All right, one last question.
Hi, Arne from Germany. Thanks for the presentations and your work at a whole. My question is for the whole panel, how you manage the pain education with the refugees who speak another language. So not only in your study, so you maybe have a translator, but in the practice, in the daily practice. So how can I do?
About pain education. So we use the interpreters for pain education. And we're lucky where I am, we have very good interpreters. So I usually have the same one for anyone who's Bhutanese or who's Somali. And so the interpreter will relay the information, and you try to make it as simple as possible, explaining to them that there really are changes that happen in the brain with chronic pain. And the more you work with the interpreter gets it down, and they actually learn, and they're really, really helpful. And actually, April was telling us a story the other night with the interpreter said to her, "Don't you want to go over this too?" So I think having a good interpreter really makes a difference. But it's a lot of double checking and making sure that they are understanding what you're trying to convey. I mean, it's not easy to do the pain education at times with someone who speaks the same language as you do. I find it hard even treating domestic Americans who have had chronic pain and explaining it to them and getting them to understand it. But I found the clients to be very, very receptive. I don't know if you want to add anything, John.
Time is over, but also culturally, understanding the cultural expectations about pain in different cultures or tribes also helps a lot. So we work with interpreters that are trained and they understand the kind of work that we do, and they also help us to explain some of the things about pain from a cultural perspective, which are very important to us to understand.
Thank you all so much for your attention. We'll be up here if you want to come talk to us. Thank you. Enjoy your evening.